Good morning. We'll go ahead and get started. It's my pleasure to welcome everybody to the 40th annual Edward Massie Lecture. Edward Massie was a prominent cardiologist here at Washington University, where he joined faculty in 1938 after finishing training at Barnes and Peter Bent Brigham Hospital, where he worked with Paul Dudley White, Sam Levine, and Soma Weiss, some of the early giants in cardiology. And he was a national leader in electrocardiography, co-authoring seminal textbooks in the field and developing criteria for computer interpretation of ECGs. He was also one of the founders of the scientific councils of the American Heart Association and served as governor and treasurer of the American College of Cardiology. He was also a very active clinician with a large referral practice, and he retired from WashU in 1988, where he became an emeritus professor of clinical medicine. And this lectureship was established in 1984. So this is the 40th annual lecture. And if you look in the pamphlet, there's been a veritable who's who of speakers for the Massie lectures, leaders really in both cardiology, electrophysiology, and arrhythmias. And today is no exception, and I'm very pleased to introduce this year's Massie lecturer, Dr. Natalia Trayanova. And Dr. Trayanova received her PhD in biophysics from the Bulgarian Academy of Sciences, and then did postdoctoral training at Duke, and then held faculty appointments at Duke, Tulane, and Johns Hopkins universities, and was also a distinguished Fulbright visiting professor from the University of Oxford. And she is a international leader in both really, it's both arrhythmia research as well as the use of artificial intelligence. She holds the inaugural Murray B. Sachs Professorship in the Department of Biomedical Engineering at Hopkins. And she's also a professor of medicine and applied mathematics and statistics. She directs the Alliance for Cardiovascular Diagnostic and Treatment Innovation, the AI Research in Health and Medicine and Data Science, and the AI Institute, and she also directs the Computational Cardiology Laboratory. Her work is really, in the stratosphere in terms of new discoveries. She's pioneered the development and the use of patient heart digital twins to represent the functioning of individual patients' organs and hearts. And her use of this kind of personalized heart digital twins and deep learning, she's developed new technologies for accurately predicting risk of cardiac arrest and for not only risk prediction, but therapeutic delivery of catheter ablation therapies in patients with heart rhythm disorders. She's received the NIH Director's Pioneer Award. She's published over 450 papers and book chapters in the most prestigious journals, including Nature Cardiovascular Medicine, Nature Communications, and so forth. And she's an inventor on numerous patents and patent applications filed worldwide. In 2019, she was inducted in the Women of Technology International Hall of Fame, an honor conferred to only 5 women each year from across the world. And she's received numerous other awards, including the Distinguished Scientist Award and the Zipes Distinguished Award from the Heart Rhythm Society, and the Hodgkin-Huxley-Katz Award from the Physiological Society. It's really my pleasure to introduce Dr. Trayanova for the 40th Edward Massie Lecture. She's going to talk about advancing arrhythmia care with digital twins and AI. Dr. Trayanova.
Hear me? Is the sound okay? Oh. Thank you so much. Thank you for this introduction. Really appreciate giving me a bit of, who is that? So I am really honored to be here and to give the 40th Massie lecture. I came the day before yesterday in the evening, and yesterday I had a wonderful experience. I gave a talk at the Center for Cardiovascular Research and met with many people. It is just spectacular research that is going on here, and I'm very pleased to be able to sort of get a glimpse into it and to meet many of you. The lecture that I gave yesterday was different. I am repeating only one study, so I apologize for these who were at the other lecture for that one study repetition. The rest of the lecture, the two lectures do not overlap. Again, it is such a great honor. WashU has a very special place in my heart, and I was telling some people yesterday why that is. But anyways, I have a lot of friends here, and I am always delighted to be here. So again, thank you for this honor. Advancing arrhythmia care with digital twins and AI. Well, first of all, I have no disclosure. I'm asked to do that. So what is our AI and then digital twins? What is our expectation of AI in medicine? The vision is that we will be able to, Okay, I'm sorry, there we go. The vision is that we will be able to use all sorts of clinical findings, biomarkers, imaging, device recordings, anything that can be gathered about the patient, and we will be using AI to provide information for the best diagnostic, prognostics, treatment, all this within the understanding of what precision medicine or personalized medicine is supposed to deliver. So when I talk about our studies today, in a way we fit in a small part of this great vision for what AI is supposed to deliver. What is a digital twin? This is the other part of my title. So a digital twin is basically a mechanistic computational model. However, it is now a buzzword, so a lot of people are using it, but it has been a lot of misunderstanding and what it could be. So there was a consensus document that was published about a year ago on what is digital twin and what are the gaps in this research. So according to that document that is written by the National Academies, it is a set of virtual information that mimics the structure, context, behavior of a natural, engineered, or social system. The important thing is that there is a connection between the digital and the real object, and it enables data exchange between the physical and the virtual system, but it's a dynamic entity. So it basically is the system with all the parts and their interactions. And the important concept behind digital twins is that it is able to issue predictions beyond the available data to drive decisions that realize value. And this is particularly important because it makes a really good difference between what a computational model is, which can be used to study to acquire mechanistic insight, and what a digital twin is, which really has to deliver predictions that drive decisions which realize value. In medicine, the digital twins are used or understood to be used to mimic the spatial and temporal characteristics of a patient's organ. And you can see here the representation of the interaction, how data come from the real system into the virtual system. These are mechanistic simulations that can predict and optimize treatment outcomes, so prognostication. They are able to test before you treat. You're able to play out scenarios for what is the best treatment, and is able to provide a more informed clinical decision, personalized therapies, and to minimize patient risk. So this is the concept of the digital twins. We have written, as I said, this concept has really exploded. Cancer now is like really making very big strides in using digital twins. So we wrote this sort of a perspective paper in 23 about what digital twins can do in medicine and how that can inform clinical decision making in all fields of medicine. In my hands, I use the digital twins for cardiac prognostication and decision making. And of course, regarding arrhythmia, there are basically two big groups of arrhythmias, the atrial and the ventricular, based on the organ. And the atrial are more frequent. About 2% of the population worldwide has atrial fibrillation, while the ventricular are little. And we create digital twins of both of the ventricles and atria to study the different types of arrhythmias and provide informed clinical decision making. So a heart digital twin, we are particularly working on the electrical system. We are representing the electrical functioning of the patient heart. So we can look at wave propagation in a patient's heart and what causes an arrhythmia to occur. You can see here a recirculating wavefront, which represents an arrhythmia. We have used that both to identify the arrhythmias, to guide arrhythmia, and also for prognostication of sudden cardiac death. And this is sort of represented in this slide, where we use medical images, health records, clinical recordings, and we use it for prognostication, clinical decision support, and for interventions that accounts for the response of the patient. And this is a very important component of how digital twins can help decision making, and I will get back to it as well. We wrote this perspective in Heart Rhythm about what is the overall utility of the digital twins, if you're interested. Another important point that I want to make is that the digital twins also exist in very tight connection with AI as well, because we use AI to construct the digital twins, as you will see later, but also they participate in other parts of the solution of digital twins and so forth. So while these two methodology can be used on its own, then there is also an overlap or integration of these two methodologies in some of our studies. So I want to talk first about sudden cardiac death. And when we have, let's say, patients with an infarct, as you're aware, electrical impulse propagation occurs through patches or regions of infarct, and very often we will have a block and then a reentrant activity will occur. So that's an arrhythmia. For ventricular arrhythmias, as we know, that could be a little episode, and as the heart cannot pump blood. The question is, how do you make a prognosis? Who is at high risk for sudden cardiac death? As you probably know, the clinical criterion is ejection fraction less than 35%. What is the accuracy of this clinical criterion? Well, for one patient that has therapy, the therapy is delivered appropriately, we have 19 for which do not derive benefit from the defibrillator. And so the strive is here to come up with a better prognostication, who is at high risk for sudden cardiac death, so they can be adequately protected. So our first foray in that was in this paper published in Nature Communications, where we created digital twins from imaging and other data, and then we used these digital twins of the patient to figure out whether in this specific patient it is likely that arrhythmia will be able to occur. In this first study, we used patients with ischemic cardiomyopathy, and here is how we generate these digital twins. So you can see here the patient MRI, you can see here the white is the infarct. We do segmentation of the geometry of the heart, and we segment the infarct and also what's called the border zone. We do 3D reconstruction, and you can see the distribution. The border zone is important because it contains sort of a semi-viable cells that have very strong arrhythmogenic properties. So this is how the geometrical model of the patient heart, of the digital twin, is generated. Now, this slide is a little old. Now we use AI to generate that. We are not going to sit down and, manually mark anymore the boundaries. AI makes those decisions and reconstruct basically the digital twin. Once this digital twin is reconstructed, then we assign electrophysiological property. This is just a geometrical model. We assign electrophysiological properties in proportion to the signal intensity in the MRI. In other words, there is sort of a normal properties here, altered electrophysiological properties here, and that is the scar. And we create this digital twin from the patient data. And in this first study, we had 41 patients, cohort of 41 patients at Hopkins. They all were deemed at high risk, and all of them received defibrillators. And they were followed for like 5-6 years. The simulations that we did, the digital twins, were completely blind to the clinical outcome. We received only the geometry. And then what we did is we generate the digital twin, and then we pace from a number of locations to see where the arrhythmia originates. And in this slide, I'm showing 32 of these digital twins of the patients. And in 10 of them, you can see while they have infarcts and border zones, no matter what we did, we could not induce arrhythmia. While in the other shown here, you can see the actually this is a movie but didn't play. It's the recirculating wave, and those were predicted to be at high risk of arrhythmia. Now, again, I'm repeating, according to the clinical criterion, all 41 patients were at high risk. And we demonstrated that that's actually not the case, that some of them received defibrillators without needing them. So here is how our predictor, we called it virtual arrhythmia risk predictor, performed. You can see the hazard ratio, that's the ejection fraction, and those are the gray zone or border zone volume, scar volume, and LV mass. Those are predictors that have been occasionally used for stratification of patients. Basically, only our digital twin predictor gave performance that had a high accuracy. Then we repeated this study for patients that were at low risk to demonstrate that in these patients, we were able to capture those who were deemed at low risk by the clinical criterion, but actually they had really propensity to arrhythmia. As you know, majority of the patients who are not, 2/3 of the patients who are do not have ejection fraction below 40% actually can die in the prime of their life. And this is a big issue, one of the big issues that we face currently in cardiac electrophysiology is how to prevent that. And so this criterion, our digital twin predictor worked very well also for those patients. So then, since this was for patients with ischemic cardiomyopathy, we wanted to kind of move to more complicated diseases, and also we decided to incorporate AI in this predictor. The reason we wanted to do that, because the digital twin uses mostly the information from imaging and some known electrophysiological properties, but we wanted to also incorporate other clinical data that is available for the patient. So then we merged, as you see, the digital twin with AI to predict the risk for patients. And this was our first study. It was published in Science Advances, in which we used that for cardiac sarcoidosis. So cardiac sarcoidosis is a disease, as you can see here, it has severe inflammation and also interstitial fibrosis. And what we can see the inflammation on the PET scan, and also there is a fibrosis and scar on the LG MRI scans. So in this study, it was a cohort of 45 patients, and both of them had LG and PET scans. And on both scans, it was fibrosis and inflammation was visible, and 16 of them had a clinical VT, about 36%. Now, again, I'm repeating, we are blind to that clinical outcome. All what we receive is basically the scans. So what we did is we did the digital twinning, which is the mechanistic modeling. So we combined the PET and LG and knowledge of electrophysiology, and we basically, for each patient, we had arrhythmia propensity results. So we would pace from many sites, and we will figure out whether in this patient there is an arrhythmia will occur. And this is really a very rich multidimensional data from the simulation. And then we would combine that with additional imaging data, with clinical data. We do a random forest selection to figure out what are the most important features. And then we constructed what's called the CHI risk predictor, which is a computational heart and artificial intelligence risk predictor. You can see, I wanted to show you that. You can see the actual model is constructed from, as I said, from regions that have inflammation, regions that have fibrosis, as well as overlap. You can see it's quite heterogeneous in terms of properties. The other fact I wanted to point out is we had only 45 patients. So because the simulations are really mechanistic, basically the machine learning algorithm does not have to learn that behavior, the physiological behavior. We already inputting it into the risk predictor. So here is the performance. You can see here we have fairly similar sensitivity, specificity, and pretty high area under the receiver operating curve for cross-validation and testing. And let's compare for the same patients what was done in the clinic. So when you use ejection fraction less than 35% to look at the sensitivity, it's very unbalanced, very low positive predictive capability. Presence of fibrosis on LG MRI, also low specificity and fairly low positive predictive capability. Abnormal uptake on PET, it has low specificity and also low positive predictive value. Instead, we have a very balanced sensitivity, specificity, and high predictive capability. This was only in 45 patients. So what the advantages of this combination of a digital twin with AI, that you incorporate all the available data. So it is a very promising predicting approach which allows to incorporate data from multiple modalities. You can combine all the imaging data in a single digital twin and works very well on small cohorts. And as the algorithm, as I said, does not need to learn any physics or physiology relationship. They embed it in the results from the simulations of the patient's digital heart. Okay, so this was predicting risk of sudden cardiac death in these diseases. Now, I want to show you one of the studies in which we used only AI. And in our hands, we use AI predominantly for multimodal deep learning for prediction of risk of sudden cardiac death. And what does it mean to have a multimodal AI? So multimodal means you're taking a lot of modalities of data. Can be imaging. Here is, for instance, one type of MRI. Can be electronic health records, other type of records, temporal signals, like ECGs, you can have cine, you can have echo. So basically, these different channels take different types of data and they combine it, fuse that, and provide a risk stratification for the patient population that is being predicted. So we use this our first foray in that was in this paper, sudden cardiac death prediction using deep learning. This is the only study that I showed yesterday and I'm repeating today. This is our cover of the paper and our little neural network here. So those are patients, as I said, with ischemic cardiomyopathy. And what we did is, first of all, the title of the algorithm is called SCAR, which is Survival Study of Cardiac Arrhythmia Risk. What we did is we had LG MRI images and also clinical covariates. And so this is a multimodal neural network with multimodal predictor with two inputs, the imaging data and the clinical covariates. So the imaging data are fed through this neural network, and the clinical covariates, this is convolutional neural network and this is a shallow network. What is interesting about this study is that we combined it with the survival analysis because we had data for the patients over 10 years. So by combining it with the survival analysis, we were able to predict time to sudden cardiac death, not only whether there will be an event or will not be an event, but when it will occur. And for each patient, we were able to generate this patient-specific survival curve. So we predicted sudden cardiac death probabilities up to 10 years. Now, the other very important distinguishing feature of this study was that we did not segment the imaging data. It is really difficult, time-consuming, and fraught with a lot of inter-operator variability, segmenting the scar from the CMR images. So we came up with this very novel algorithm in which we feed the data to the algorithm, raw DICOM images. So it does its own learning based on the signal intensity. So here is our internal cohort. Those were patients collected from hospitals in Maryland and Delaware. It's a Hopkins cohort. They were all at they had very low ejection fraction, 156 patients. That's the internal cohort. Also, the external validation cohort was a quite different patient group. They had a much higher ejection fraction. They were kind of medium risk. They were not high risk. And also they were collected from 60 hospitals across the country. This is the predetermined study, and they 113 patients. What I wanted to point out that we did not eliminate any images because they were bad or anything. The scanners were completely different. We eliminated 2 images only because they didn't take the whole heart. They didn't scan the whole heart, but the rest we took. So here is the performance of this algorithm. You can see here we have, for the internal cohort, we have a very high number for the ARC. And again, I'm repeating, this is a prediction over 10 years, time to sudden cardiac death. That's the external cohort, which was very different. Still, we have a pretty good predictive capability over 10 years. And this is the precision recall curve. And it's an example of a good prediction. This was a predicted time to death. This is the actual time to death. And here is a bad prediction, because the prediction actually carries in itself the uncertainty in the prediction. So you know how certain the prediction is, how uncertain. This was fairly uncertain. You can see the flat curve. And so I just wanted to contrast these 2 examples. We also provided interpretable outputs, variables that, on this side in blue are those that when they are larger, the risk of sudden cardiac death is less, and the other way around. And this is interpretability on the images, which demonstrates which regions of the heart are actually most important for the algorithm when it's picking up. So you can see here a patient that actually has infarct, but it did not deem this patient to be at high risk. Here we have another patient that the algorithm deemed at high risk, but it picked other areas also as very important. So it's this geometrical combination of the location of the scar shape, etc. So we think this was a pretty awesome, novel, very novel algorithm that we developed. Again, it offers accurate prediction up to 10 years. For the first time, uses raw images and predicts the distribution over that time, and it also generalized very well. So as I said yesterday at my talk, I'm showing this study again because I term it the pinnacle of my career because it was mentioned on Saturday Night Live. So it really is. Another thing I wanted to mention here is the first author of this paper as you saw before, it was in Nature Cardiovascular Research. The first author was my grad student. And he, after he completed his PhD, he was hired by Goldman Sachs as their vice president for data science. So it's been an incredible sort of a roller coaster ride. It was a paper was like first news on Apple News, on Google News, and anyways, and then he got hired to lead Goldman Sachs data science. So anyways, I'm very proud of him and of this research. And we also wrote a, sort of an overview of these approaches with Dr. Eric Topol, who gave the Massie lecture back in '96. That was in the Lancet. Okay, so I want to show you something that is unpublished, but it will be published very soon. The paper is accepted in Nature Cardiovascular Research as well. This is a multimodal deep learning for risk stratification in patients with non-ischemic cardiomyopathy. And our first foray in non-ischemic cardiomyopathy was these patients with hypertrophic cardiomyopathy. As you know, this is a disease, common genetic disease, thickening of the myocardium, and it leads to ventricular arrhythmias, and the clinical guidelines do not accurately predict the risks. So we did a pretty extensive study. This is our development cohort. It's a Hopkins cohort of 819 patients, of which 553 had LG MRIs. So we are using those. And so again, we are using the raw images, and also we are using, as you can see here, demographics, medical history, all kinds of stress test data, baseline, anything that we could collect for these patients. And then we had an external validation cohort, was at Wake Forest, Atrium Health, and these patients, of course, they're different demographic group, and also we collected exactly the same data. So we have an internal and external cohort. And again, in this case, we have images, raw images, electronic health records, and the CMR and echo reports. All that goes into the risk predictor. Now, an important contribution of all these AI predictors is you gotta do better than the clinical guidelines. And I have been showing you this, but here we really compare the predictions of this algorithm to the ACC/AHA guidelines for hypertrophic cardiomyopathy with the ESC guidelines, and there is also an HCM risk calculator. So all of our predictions were compared to these clinical guidelines. And so let me show you first the prediction in the internal development cohort. So on cross-validation, this is our prediction, 0.89 predictive capability. You can see here the ESC guidelines, the ACC guidelines, they are almost like a random chance in this group of patients. This is the external cohort. Similarly, very high performance in the external cohort, and you can see the guidelines also did not, the risk calculator did the best, but not too far from a toss of a coin. The important thing I wanted to highlight is from the development to the validation cohort, it didn't change very much from 0.89 to 0.81, the performance. So this is very important because it generalized very well. It's only 0.08 drop in that performance. So then we tried to see, when you say I have a multimodality, why are you using multimodality? You have to demonstrate that the multimodal predictor works better than any of the single modalities. Otherwise, you don't need that. And it did. It performs better. You can see here the combination works the best. So then what we did is we did evaluation of subgroups. We wanted to check gender. Well, not gender, sex, sorry. You can see female, male, and also we wanted to check age, the age groups. You can see here 40, 40 to 60, over 60. We have a really very good performance in both male and female, so it's equity in it. You can see the clinical guidelines are much worse in both male and female, a little worse in male. In terms of age groups, we had very high, again, predictive capability. And you know, hypertrophic cardiomyopathy is basically a disease of younger people. So you can see here in the age group where you have a lot, you know, a fairly high occurrence, really performs these, some of the clinical guidelines perform quite poorly. Also in the less than 40 years, really poor performance, while we had ours was much better. We did also what's called the discriminative risk score. You know, how well does the algorithm separate patients that have high risk and those that don't? And this is the clinical guideline performance. The number, the K here, shows how well does it discriminate. And you have to have the separation of the red and blue histograms. Well, for the clinical guidelines, you do not have very good separation, and it's very low K factor. So you can see our predictor. This is the separation guideline. We have a pretty good discriminative capabilities. Actually, the raw images had the highest K value, discriminative risk factor. So our algorithm is able to do that. So we also did interpretability. Here is one patient. You can see this patient had, we predicted will have high risk of sudden cardiac death. And then you can pull out which are the main contributors to this high risk. In this patient, syncope, the fact that he had syncope, was the feature that brought the risk above the threshold. So the red values are those that would increase risk, and the blue are those that decrease. Another patient, in this patient, it's the non-sustained ventricular tachycardia brought the risk very high. You can say, well, this is kind of, you know, obvious if they have non-sustained VT. But this patient had non-sustained VT and did not have a high risk. And the reason was it had a very good echo features. So it's not always what, you know, we might think. There are very, so the fact that you can pull for every patient what was the features they led to the highest risk is actually very important, because you can do, you know, lifestyle changes, etc., or take other preventive measures. So what we learned from this is that multimodality far outperforms the clinical guidelines. The raw, using the algorithm on raw MRI is very important, because MRIs are so underused. There is so much information, and normally it's reported in radiology 1 or 2 numbers, while here we are using the whole volume of data that's contained within the images. It generalized very well to the external cohort in a completely different healthcare system at a geographically separate location, and exhibited fairness to patient subgroups. Okay, so this is, I showed you some combination of AI and digital twins, some AI research, and now in this last part, I want to show you just the use of digital twins. Now we are moving from prognostication actually to treatment, and in this case, for ablation. So for what are the arrhythmia treatment strategy? Of course, one can do antiarrhythmic drugs, but the important current strategy is to use ablation, of course, both for atrial and ventricular arrhythmia, where the ablation is aimed at regions that are sort of anchoring reentrant waves or have a trigger. And so by ablation, we terminate the ability of this tissue to propagate electrical signals and thus eliminate the perpetrator. The question is always where to ablate. And to do that, currently in the clinic, use electroanatomical mapping, map around, and try to figure out where to ablate. What we here are proposing to use the patient's digital twin to be able to predict where to ablate. So this is the first paper in which we propose to do that, to use the digital twin to do that. And as I described before, you basically construct the digital twin from the contrast-enhanced MRI, the LG MRI, Then we pace from a number of locations. We reconstruct the digital twin, incorporate electrophysiological properties that are different in non-remodeled and remodeled border zone, and then we simulate the arrhythmia. We find where the locations are, and they are the targets of ablation. Now, a very important concept in digital twins in our hands is that we don't want to stop at this point. We predict where to ablate. What we do is we want to predict where to ablate, then you put the lesion back in the digital twin because the lesion is a scar, and you have the landscape of distributed scarofibrosis, and you're doing more scar. So it is possible that when you deliver the lesion, there will be new arrhythmias that will occur in this new substrate. So this is the ability of the digital twin to take into account what happens after the treatment to improve the final outcome. So what we do is we would identify the lesions, put them back in the digital twin, pace from many locations, and identify what we call emergent ablation targets. And we repeat this until it is non-inducible for arrhythmia. And then we export that to the EP room. It's displayed in the CAR2 system, so the catheter can be navigated directly to the targets. Now, there is currently no mapping system, neither catheters nor specific mapping system that can do that. Demonstrate what happens after you execute the lesion. And what is the type of ablation? We are agnostic to that. We just predict targets. And I showed this example yesterday as a sort of impetus for the studies that followed. This is an analysis of one patient that underwent ablation, ischemic cardiomyopathy. We just got the MRI scans. We are completely blind to what happened with that patient. So we analyzed it, and we predicted these 3 locations for ablation. And this is a retrospective analysis. The patient had been ablation. And then once we completed the analysis, we received the clinical data. And so this is the first ablation procedure of this patient. You can see a very good co-localization of where we predicted and where the patient was ablated. You can see our prediction is much smaller in volume. But what happened with this patient is that patient came for redo ablation after 7 months, and that's where they ablated. So what that tells you is that if you use the digital twin pre-procedure, you can predict all the locations, not only those that eliminate the current arrhythmia, but those that will become an arrhythmia after the ablation. So this, as I said, was an impetus for for current studies. Yesterday, I demonstrated how we validated that in the clinic with our predictions with invasive data. And today, and then I wanted to show where we are going with that. So we have done at Hopkins some prospective patients. It's a FDA-approved IDE. We're now analyzing that, but what I want to focus is on this, which I didn't talk about yesterday. So it is the new generation. After we did that, we decided that we want to move into some of the diseases that might have genetic aspect, and so I want to show you our studies of ARVC and how we predict where to ablate patients with ARVC. So we call this genotype-specific digital twin because we are incorporating the genetic information for these patients. So this is our first study in arrhythmogenic right ventricular cardiomyopathy. It's an inherited disease, as you know, primarily affecting young adults, but a catheter ablation, it's a mainstay, but quite difficult. It's extensive mapping, and a lot of these patients have a very high recurrence rate. So this is a paper in which, for the first time, we developed these digital twins. I want to show you now an unpublished study. In this, so I will show you 2 groups of patients. They have 2 main genotypes, PKP2 mutation and gene elusive. So this is how we use this GenDirect, this novel type of digital twin. We use the LG CMR scans. They are harder to segment because we have now the right ventricle, which is much, much thinner. And then use the genetic testing data, and then we segment and construct the digital twin. We use the genetic testing data to create a cellular model for the patient that is in correspondence to the genetic information, and all the cellular model is part of the whole digital twin is populated with the different cells that have the specific genotype, and then also we have a border zone that has a different action potential morphology. You can see here the cells in the two types of patients have different morphology and different behavior. So that is combined, and we are using this to predict ablation targets. So in this study, we had 15 patients of one type and 15 of another. And so here you can see we are trying, this is a digital twin of one of the patients, and we're looking at the right ventricle, and we are trying to induce VT by pacing, rapid pacing protocol, and you can see it, VT is formed, and you can see the reentrant circuit. So here is the predicted lesion in orange, and you see when the lesion is done, no arrhythmia occurs after. So if the patient cannot, if in this patient we no longer can induce arrhythmia, then this is done. Our prediction is done. However, it is possible, and then we finalize, but however, it's possible that there is more arrhythmias after we do the target. So here we are pacing again, and you can see we have the lesion there. No, this is repeating, I do not know. Okay, so we recheck the inducibility. You can see here we are rechecking it. And then these are the new lesions as this arrhythmia was identified to be here. We executed these lesions, and then we have no more emergent ventricular arrhythmias. And so the final ablation lesion was, the set of ablation lesions, I'm sorry, was this one. Okay. Okay. 25 of these 30 patients were ablated once, and they were fine. 5 of them came for repeated ablation. So what we wanted to compare, this is a retrospective study, what we wanted to compare our prediction of where the ablation is with what was done in the clinic, of course. And then the first thing is we had a very high concordance of where the targets were. The average DICE score gives colocalization of predicted and clinical targets. So you can see here, for instance, the orange is the GenDirect prediction, and here where the ablation. We were blind to the outcome. This is a retrospective study. This is our prediction. It is a smaller target, but it co-localizes where the patient was done. Similarly, we predicted here and here to be ablated, and those were the lesions that was done. Our prediction in orange, and here is where it was done. First of all, our volume of predicted where it needs, the tissue has to be ablated is much smaller and significantly smaller. For these patients on an index ablation, we were able to predict very well where the clinical ablation targets were executed. Now let's look at the patients who came for repeat ablation. You can see here, in this patient, we predicted 3 targets. Here, here, and here. It was ablated at these 2 locations. After 11 months, the patient came back, and it was ablated here. Okay, another patient, we predicted that it needs to be here and here, and when the patient came back, it was ablated here. Look in this patient, this target was not done. When the patient came after a month, it was ablated here. This patient came twice, a lot of targets. This is our prediction. This is the first ablation, second ablation, third ablation right here in green. So in all these cases, we were able to predict pre-procedure, not only the lesion that will terminate the VT, but also the emergent arrhythmias after the ablation. If these patients who have been ablated, guided by our technology, then they would not have to be rehospitalized. And you can see also the volume of the lesions, which was much smaller. So GenDirect is able to predict non-invasively, pre-procedure, all the targets that render the substrate non-inducible, and that includes these emergent VTs and also minimizes lesion size while ensuring efficacy of the therapy. It's a very versatile framework, can be applied to other diseases, such as also gene therapy, etc. So this study, as I said, is not published. It is submitted to a really high-level journal. We have undergone one revision. The student who was the first author in this paper was a finalist in the clinical category. She is a PhD in the clinical category in the Heart Rhythm Society meeting 2 weeks ago, and she also received the Sachs Foundation first award for best paper. So I'm really very proud of her for the work. I think I also wanted to show you this. We had the Wall Street Journal wrote an article about the digital twins that we are doing, because yesterday I talked a lot about this. I talked mostly about ventricular digital twins, but yesterday I spent a lot of my time talking about creating digital twins for the atria, and we have a randomized clinical trial demonstrating that we can use digital twins for patients with persistent atrial fibrillation and fibrosis on LG MRI. So anyways, the Wall Street Journal wrote an article, and I'm showing you this because in the article they talk about the clinical trial and atrial stuff, and they wanted me to give them a visualization. So I gave them an atrial movie, biatrial arrhythmia, we predict where to ablate. The editor looked at it and said, "What is this organ?" And I said, "Well, that's an atria." He said, no reader will know what an atria is. So give us something else. So I gave them, this is actually from this ARVC project, is the movie. On the website, it actually plays. But it's funny, the article mostly talks about our clinical trial for atrial fibrillation, and they have a ventricular movie. So anyways, I want to conclude my talk with these sort of messages that heart digital twins are demonstrating significant predictive capabilities in clinical outcome prognostication and treatment planning, and together with its sister technology, they are poised to be a major tools in precision medicine and cardiology. And of course, I have to acknowledge all the people. I collaborate with a lot of people, the Hopkins clinical and imaging team as well, and the members of my center and collaborators, and my students. It's just, they are amazing. And I have to end with that. Thank you guys very much.
So thank you very much for that really inspiring talk. I'm going to open it up for questions. Are there questions in the audience? Maybe, Corey? Yeah.
For clinical trial?
Enrichment strategies.
Aha.
Make sure clinical trials contain the patients that are highest risk and most likely could benefit from a tested therapy-based practice.
Absolutely, yes.
Let me just repeat the question for those on Zoom. So the question was, can this approach with AI be used for clinical trial enrichment in selecting patients?
Yes, I think it can be used. So there is a whole sort of a pathway that actually the FDA is supporting for what they call in silico trials, not just for enrichment, but also particularly for drugs and other therapies, to basically generate either cohorts to supplement clinical trials or to just have entirely in silico trials, and you can generate synthetic data. You know, you can, let's say, have a patient cohort, and you want to make the cohort bigger, and you can use basically either AI or other algorithms to create a cohort that has the characteristics that are similar to the patient cohort that you need to enrich, let's say, or to represent, and they have the similar characteristics for distributions of remodeling or other phenotypes. That can be done. And it is, there is actually even a company that is called In Silico Trial, and they provide, you know, if, not just for cardiology, but for other aspects of using the digital twins in medicine.
Other questions? Maybe I could ask one about, so this is a beautiful merging from, you know, in silico work to clinical trials. Can you comment on if this approach becomes more widespread, what's the scalability of this kind of, you know, guidance for therapy?
Yes, so in my lecture yesterday, I touched on the issue of scalability or democratization and so forth. You know, currently, digital twins are they are time-consuming to generate. They're very mechanistic. They're very high resolution. I have a cellular resolution in these models. They're deeply mechanistic. I can pull the calcium cycling if I want throughout the organ or any other behavior of a channel throughout. So they take a long time to do. And in our clinical trial, when a patient comes for AF ablation, we take like 4 to 5 days minimum between the scan to the actual procedure, so we're able to generate that, and we run that on the mainframe computer. And that is not scalable, of course. So we have been working very, very hard to try to figure out how we can bring that much more in an integral part of the clinical workflow when it is done on the fly. And so one aspect of that was developing the AI technologies for the segmentation in image processing, which is done. And the second aspect is that kind of bottleneck of the solution. And so I talked yesterday about a new approach, which is an AI approach that we developed that can work for any engineering problem where your AI algorithm actually predicts the solution of the differential equation, so you don't have to run that on a mainframe computer. It takes a few minutes. Well, it takes 1 second, but when you have the imaging edit, so a few minutes on a desktop computer and can be brought on a single GPU. So that's where we are going. So those are brand new technologies. We just published some of it. We are working on increasing the applicability to other you know, types of remodeling. That's where we want to go. So very short execution in the simulations, and like we've created the pipeline. This is a completely automatic from image generation to prediction. It's automatic. It's just that it takes a long time. So we eliminated that part now.
Stacy?
That's a great talk. If you had your wish list of something that the field could, some information that you could have that could make this better, for example, with PKP2 mutations, you incorporate that into the model, so you must, you know, be using some electrophysiologic data. What could make it even better?
I mean, I touched on that yesterday, is I want to make every digital twin heart, the action potential to be fully personalized. And we have created a new algorithm for doing that, machine learning, where you take the patient clinical data, the algorithm is trained on a cohort using the clinical data and electroanatomical mapping, and then it generates basically parameters that go in the action potential model for each patient. And for the cases when we have a mutation, that goes directly in there, so it generates those. And we have not yet incorporated that in the digital twin. We just presented it at HRS as a standalone sort of a machine learning algorithm to do that. We intend to incorporate that. So that's our way towards personalization of every little aspect of the digital twin, and also the scalability across healthcare centers.
Justin?
Fascinating talk.
Thank you.
I had a question about the sudden cardiac death risk prediction, and I apologize if I missed this, but were all the clinical risk factors based on baseline levels? And what I was wondering is, does the model or the prediction tool give any insight into how medications and titration or adjustment over time modify the risk of sudden cardiac death?
Okay, so When you say baseline, what do you mean?
I didn't know if it's taking sort of a snapshot of the patient's, again, their clinical, their medication regimen, for instance, and then looking at risk prediction sort of based on that baseline, or if there are updated.
Okay, got it. So you can do both. You can do both. You can, the algorithm can take data at one point of time and then another point of time. That is seamless. We can do that. We have actually, we are using the similar algorithm, incorporates ECGs taken at different, all that can be done. For this, it was at baseline, okay? But it's not limited to that. In the algorithm for sudden cardiac death, you can see that the ones that we had follow-up for 10 years, you have a lot of, so it's learning on these predictions over the 10 years. So clearly you can do longitudinal, data, absolutely. So hypertrophic cardiomyopathy baseline, the ischemic cardiomyopathy that I showed, longitudinal study over 10 years.
Okay, any other questions from the audience? If not, I want to thank Dr. Trayanova for an outstanding Massie lecture presentation.
Thank you. Thank you very much. Thank you.